I'm going to start now. So I want to thank organizers for inviting me to give this talk on multimodal treatment strategies for knee joint dysfunction. And I'm going to share my experience with patients that are complex and difficult to treat throughout this lecture. Uh, Once again, this is the hospital I work at in Baltimore, Maryland, and this is the Orthopedic Institute where I work at for last 20 years as a chief of orthopedic rehabilitation. No results that I show you today are without my staff's participation. This is my staff of the musculoskeletal therapy that happens in our institute. And you can see we have a very varied multinational staff that we have. Majority of them are physical therapists, and there are a few occupational therapists as well as engineers also. So I want to thank all of them because they are the reason why I can present such great lecture to you. Why do patients come to us? They come to us for two reasons. One is they want their pain reduced and they want to improve their function. So those are the main reasons why we see patients with knee dysfunction come to us. And we always have to strive to make our rehabilitation better, faster, and cheaper or cost efficient. So I'm very passionate about this concept of multimodal, and I'll tell you why in a second. So what is multimodal? Is a patient comes to you like this with a severe flexion contractures, and the only option he's offered is surgery. And is it possible to treat this type of patient without surgery and still get a good result? Well, I believe physical physiotherapists can achieve such results if careful attention to how to treat a soft tissue problem is really given. And this is my case from about 15 years ago. And I will run the video slowly so you can actually see my result in a second. So you can see here, this is the fast video where he's going back and forth walking. And you can see that he's walking almost perfectly normally. And I will slow it and I'll show you again. He has full extension of his right knee as well as his left knee when he walks. And that's the type of result one can achieve with multimodal treatment strategy. And you can see the result here of full extension of the knee with good dorsiflexion at the ankle joint. Well, how do you achieve such results? So I believe in this. I believe in multimodal strategy, meaning that we have to address all of the problems at the same time. And I always give an example of multimodal treatment strategy in complex infections, including COVID-19, tuberculosis, cancer patients. We don't give one drug to the patient and expect to have the best results. In complex diseases, we have to do everything at one time. Unfortunately, in physical therapy, I see this happen too many times, where we go to these courses for manual therapy for this device, that device, and then we become certified in certain things, and we believe that that technique can solve all problems. And I think the philosophy has to change where we have to do more than one thing to get patients' results. The other thing that we have to understand that a lot of the recovery happens at home on their own. And we have to be able to give them devices, gadgets, and stuff like that, our home exercise program, that will be effective in treating the patient's knee joint dysfunction. So the philosophy of this lecture is based on the same principle as you would treat multi-drug cocktail therapies for complex diseases. And we in therapy sometimes tend to take a different approach where we will first try to do manual therapy, then it doesn't work, then we do this, then we do that. We have to do everything together for a short period of time to get the best results. And that's what I want to share with you. For example, here, I'm doing a static progressive splinting, I'm doing manual therapy, I'm doing soft tissue mobilization, and I'm doing eccentrics, and back here I'm doing patellar mobilizations. All of that, we have to start together and make the patient's functionality better. That's the concept. Well, how does it work really? Well, let's look at the case examples. So when you lose range of motion, why do you lose it? We have adaptive muscle shortening, a scar tissue adhesions, or a periarticular remodeling. These are the areas the therapist can make a difference. But once it gets to studiomyostatic contracture or chronic subluxation, usually those diseases cannot be treated just with physiotherapy or splinting or all of that modalities that we have. So this is an example of a patient who had a knee replacement and had a manipulation under anesthesia and had a tibial fracture. So now he has an extra long prosthesis and a significant loss of range of motion. So what is the problem here? So why the scar tissue became so adherent that it broke the bone when we tried to manipulate the leg? It's the scar tissue. What does the scar tissue look like? The scar tissue looks like a very dense spaghetti. So it's dense and it's together. So we have to streamline it and you have to make it striated so that we can actually disengage the adhesions that are here. And how do we achieve that? We achieve that through prolonged stretching or soft tissue mobilization or correct deep tissue massage or manual therapy. All of that put together, you can actually change the striation of the tissues. Well, how much time do we have? This is a beautiful example of a scar that looks pink here and a scar that looks like white here. So this is about 6-month-old scar and this is about 2-month-old scar. So a 2-month-old scar, usually it's pink. That means it's still going to function and be able to stretch the knee and get more motion. While as on the right side, the scar is white and it's established and usually will not respond to further conservative management. So we have a short window to improve function of the patient. So in that short window, we must do everything to get the function back. And the improvement in range of motion always depends on duration of stretch, frequency of stretch, intensity of stretch. One of the other thing that we should always remember is we should always use this algorithm for the splinting techniques or dynamic splintings, and how we use this algorithm is always evaluate range of motion and always change the total time at end range to move and tissue. And I will explain that in the next slide, please. So this is a patient who was sent to me by another physician. And if you can see here, she has a range of motion that is restricted in both her active knee flexion extension, but more importantly, also on the heel slide, she cannot extend her knee fully, as well as her flexion is significantly limited. So what did we do for her? So we did everything that I'm going to teach you in the next few slides. I did all of this. I did very aggressive patellar mobilization. I did the Mulligan's technique for manual therapy. I did a prolonged stretching at home. I did eccentric strengthening exercises, and I broke up her scar tissue with instrumented mobilization. Then the therapy total number of sessions required was only 12 to 15 sessions were required, where we were able to get such excellent range of motion, where she was able to sit in Indian cross-leg fashion, not perfectly, but much better. Her flexion had improved. And you can see here, within 12 sessions of therapy and doing her home exercise program, she has improvement in her flexion range of motion, as well as her ability to sit in Indian cross-leg. I always make all my patients sit in Indian cross-leg despite having a total knee replacement, because it stretches the IT band distally much better in this position than any other position I can think of. So that's the power of doing what we call multimodal treatment. And why do I believe in splinting so much? Is if you look at the amount of force that applies with a static progressive splint, it's only 10 Newton meters of force, while a therapist puts about 50 Newton meters of force. But if you look at it from a multiplier effect standpoint of view, meaning that if you see that here in the right-hand column, the total energy given to the joint is far greater with a static progressive splint because you're using it for about 2 to 3 hours per day. While as a therapist that pushes at 50 pounds or 50 Newton meters can only produce this much energy or only 150 to 500 because it's only used for a shorter period of time. So the energy derived to the tissue matters, and that's how we remodel the soft tissue, and that's why it's important to achieve that. And I always show this to my patients, and I tell them, I said, if your child can wear a brace on their mouth for 18 months to move their teeth and remodel bone, I am sure you can use a brace and do some of the things that I'm telling you at home to do for 2-3 hours a day for 3 months, and it will change your life. So I always show them this picture, and it's an important picture to show, putting them to shame, saying that if you do the right thing, you will do better. So, we always decide on how the treatments are based on whether it's acute or chronic, how much pain is the patient in, does the patient have tone or spasticity, what is the age of the patient, and what's the tolerance to therapy. And the last thing I always look at is, what is the joint feel like? Is it a soft end feel? Is it guarding with tone? Is it semi-rigid end feel? Is it rigid and manipulated or doorstop? With doorstop end feel, most of the times, conservative therapy management is not helpful, but all these four, one can actually change the range of motion of the tissue. So this is another example of a total knee patient, and nothing major about it, but she has developed a significant flexion contracture. So in case patient develops a contracture like this, which is about a 25 to 30 degree contracture, then you want to splint them. So in order to do that, we always do first the soft tissue stimulation, followed by a splinting technique, one for extension bracing, one for flexion bracing. These are very cheap to make. These are made out of fiberglass, and I use a simple TheraBand to put across the leg to apply extension stretch here with hinges at the knee. And then the same thing with the brace, the cast. Both are removable, and you apply TheraBand for sustained stretch. So part of the therapy for range of motion is always that, in my opinion, and it should be always incorporated. We also use walking braces to help the patients walk better, get a proper control. So we will use this extension assist orthosis in some patients when they have a quadricep lag or they have a problem initiating the gait. And once you do that, you can achieve lasting results. This is a patient where I have a 10-year follow-up on a patient, and you can actually see full extension of the knee and good flexion at the knee also, with adequate function for a 73-year-old woman. That's a pretty good function for a patient who started with significant knee problems. So the other problem we have in knee joint problems is significant quadricep weakness, or we call it arthrogenic muscle innervation. So how are we going to manage that? Well, why does it happen? It happens because of many, many factors which are down here: inflammation, swelling, joint laxity, receptor damage, joint damage. All of that does what we call a alpha motor neuronal excitability is reduced because of the inhibitory influences that come because of swelling, joint laxity, and joint damage. And then once the inhibitory influences in the spinal cord of the quadriceps occur, it is basically arthrogenic inhibition of the muscle, and that can only be bypassed by actually bypassing it right here, because one cannot, even voluntary effort is excitability is there, you still can't activate the quadricep muscle. And the best example thought of is there's a paper in 1966 that shows that if you sequentially inject your knee joint with normal saline solution at about 60 cc's of saline, you lose your ability to lift your legs straight up in the air, or you lose the straight leg raise. So 60 cc is all is needed to totally inhibit your quadricep muscle. So that's why the news of neuromuscular stimulation. That's a typical way a patient will move when first surgery, he comes out of surgery, the knee is swollen, painful, and that's how they are moving. So what about the fast twitch muscle fiber? That's the biggest problem we have in our literature. It's critical to all functional activities. If the movement cannot be achieved quickly, it will not be used in function, and pain inhibits quick motion. And it's faster to atrophy, harder to come back. and rehab protocols generally do not address it in initial phases of therapy. And this is what you don't want. This is a MRI scan of a actually collegiate athlete, and you don't want to have atrophy like this in a patient. You would rather have a postoperative ACL patient that looks like this, where there is enough mass here and good cross-sectional area of the quadricep muscle. So one of the treatment techniques for that is neuromuscular stimulation. This is the worst example of that, a knee dislocation with a multiple injuries, the PCL, LCL, MCL, all completely ruptured and partial ACL ruptured. You can see her leg is completely bent out of shape. Then she gets a superficial infection. She has significant quadriceps atrophy. So how do we treat that? The first thing we do is we get her on NMES, a neuromuscular stimulation unit, for 60 to 120 minutes a day, doing strong contractions of the quadricep muscle. So I have to go back for a second. Hold on 1 second. So we will incorporate a significant contraction, something like this, and get the patient moving their quadriceps right away. This really helps with also knee joint stiffness because it moves the patella up and down and is very helpful in reducing it. We get them to walk right away with the braces in the anti-gravity treadmill or in the water with some support. And then we also use a night brace that I showed you before that I create with a simple TheraBand to keep the knee extended because you don't want to get a flexion contracture. And then within 3 to 4 months, they can be actually very active and get back on the field and do their high velocity ballistic movement that you will see in a second here, where they are actually doing the push-ups like that. And their quadriceps are active. Their fast twitch muscle fiber did not get atrophy because we did enough electrical stimulation before, and then we always check them for single hop for distance, both from the front as well as from the side. We call it lateral hop, and then we put them on the field as soon as possible. So within few months of rehab, if done appropriately with multimodal strategy, you get their strength to equal single hop or distance, equal full range of motion, and put them on the field within 6 months from a knee dislocation surgery. So that's a pretty good rehab that one can achieve with a proper planned treatment as shown here. So going to the next one, what about the older patients? What about the patients who have total knee replacements, things like that? What do we see in those patients? Well, here is a device that we use currently for all our total knee patients. And basically it's a sleeve with a electrical stimulator here that's connected to your iPhone. And this sensor here actually measures your knee range of motion, and we can look at it up in the cloud. And it produces pretty strong contractions. And this is the waveform. It's a monophasic waveform with a pulse width of 5 milliseconds. And you can see a pretty strong contraction. I've taken the brace part off to show you how this activation of the muscle occurs. And most patients tolerate it because it's the way the waveform has been created that it's not painful, but it produces strong contraction. So we truly believe in this as a home exercise modality for all our patients. And then when you can get a result like this in 5 weeks, you have a patient walking in 5 weeks after a total knee replacement like this, it's very rewarding to see that, is that they have good gait speed, good symmetry in gait, walking well, and all of that is very rewarding to us. And you can see the functionality here of going up and down the stairs and doing a repeated chair rise test within 5 weeks of surgery. Is patients are happy like that. So the point here I'm trying to make is, combining multiple treatment strategies to address muscle weakness, range of motion, functionality, gait training, all of that goes a long way instead of focusing on one technique at a time. This is one of the difficult cases. This is a patellar tendon rupture, and this is repaired with an allograft. So there's a delay in rehab to allow for tendon graft to heal well. So here we are using a turnbuckle splint because she has lost range of motion. And you can see here, she's basically using the dial to get more motion into her leg. So you can see here, she gets that stretch, and she maintains that stretch, because we want tissue remodeling to occur slowly to actually do what we call a plastic deformation of the collagen fiber and improve range of motion. Because aggressive stretching will actually cause more scarring and more pain and less range of motion. Whereas if you do a slow, prolonged stretch, it will actually optimally remodel the soft tissue and you can get proper results. Well, these patients are very weak. This is the final range of motion in her. You can see how big the scar is. The scar was very big on her because when you have is patellar tendon rupture, she's a basketball player, the patella rides up. So you have to do a big exposure and tether down the patella with an extensor graft. And then you have to work very hard on getting the full range of motion of the knee, because she's a young girl, plays basketball. But in this period, sometimes muscle weakness is a big issue. So we have now, and you can see here, she's doing a squat or doing a straight leg raise. So we now have employed this particular technique in our practice full time. And I don't know if many of you know this, it's called blood flow restriction therapy. And it's very rewarding. It's been very useful thing for our young orthopedic patients to use, because they can get the fast twitch fiber recruitment very early on. And the principle of that is very simple, is that you are using a tourniquet at the just below the groin level to reduce the arterial blood flow by 80% and stop the venous return by 100% using a tourniquet. Now, you can't do it without using a Doppler-driven tourniquet. So we use a Doppler-driven tourniquet to restrict the range of the blood flow and exercise them at a lower intensity. So we do the blood flow restriction therapy at 25 to 30% of 1 RM exercises. And we have seen that many papers are there in the literature that show improvement in strength and hypertrophy at much lower loads than using a conventional exercise. And why does it work? Because it has hypoxic environment, it promotes anaerobic metabolism. And for me, this is the most important thing, is that how do you get the fast twitch muscle to activate? You use either BFR training or NMES at maximally tolerated intensity. So that's what our go-to method is, because you really can't do max intensity eccentrics or fast movement patterns such as limb perturbation or rhythmic stabilization in early postoperative period. So in the early postoperative period, our go-to is for BFR training with NMES, because that allows us at a lower intensity of muscle activation, actually hypertrophy of the fast twitch muscle fiber, especially in our young athletes, which is where the atrophy of that, it then takes a very long time to recruit those muscles. So that's our go-to technique. So lower extremity, we do a arterial occlusion of 60 to 80% and a venous occlusion of 100%. And for upper extremity, we do it at about 50% occlusion, and venous occlusion is always 100%. We usually do 75 reps at 25 to 30 of 1 RM for strengthening, and no more than 3 exercises are done for the patient. But with that, the literature has shown significant improvement in the cross-sectional area as well as strength of the muscles here. There's a lot of literature on this. This is on the arthroscopy 4-week study that shows that just using that gives a significant increase in the peak torque over body weight. And there are some randomized controlled trials that also show the similar gains with less. So bottom line, similar improvement in quadricep strength with less pain, because you're doing 25 to 30% of 1 RM times 75 time reps in most patients. So that's the beauty of using blood flow restriction therapy. There are certain danger signs, and we don't use it in certain patients like cardiac compromised patient, unstable hypertension, DVT, neuropathic limbs, so certain things we don't use it on. The process is very simple. you basically apply a tourniquet to the leg of the affected limb. And once you attach that, you attach the tube that comes from the Doppler-driven tourniquet. You have to put it tight enough so that it's tight, and then you have to lie down flat to get the assessment of your leg for your 80% occlusion rate, and that's how he's doing it now. And once he does it, then the next step is using exercise with it. So he's now under tourniquet at 80% LOP or occlusion, and then he's doing a knee extension exercise like this to recruit his muscles, and only doing it from 90 to 45 because he had a patellofemoral lesion. And you can also do the leg press like this, the same principle. And then he did the straight leg raise using the tourniquet driven, and he was doing, I think, 10 pound weight or 5 kilogram weight, 75 reps, and his 1RM is far greater. He's a big, strong guy. And that's the technique of using the blood flow restriction therapy for the quadricep muscle. We also incorporate that with NMES early on. And one can see here, then later on, it's NMES driven BFR with a leg press like that. So there's a variety of uses that for early to late postoperative patients, and that's how we use it. And that's how we position our NMES BFR progressive closed chain, open chain, and heavy load ballistics exercises in the recovery of our ACL patients. So you can see here, this is weeks, and this is your exercise load. This is your volume of load, and this is your intensity. And you can see the intensity goes up gradually, and your load increases initially and then tapers down. And then you're doing basically heavy load ballistics here. But you start right here, add BFR to that, then go to progressive closed chain with BFR, and then finally go to heavy load ballistics. And that's our recovery pattern for our patients that we use. Going back to a very stiff knee again, just to show you another example of that. You can see here a very stiff-legged gait and very atrophic leg. You can see that there's hardly any muscle there. And that's the total range of motion. Why did it happen? She had a total knee and she got injured in a car accident. So she had double whammy. And with that, her range of motion, you can see, again, significant restriction. That's all she's got, a very difficult movement. And I treated her the same way, multimodal treatment strategy. And you can see not only she has, but she has good muscle, good quadricep muscle, and a reasonably good range of motion for a total knee. And then eventually that's her gait. So what I want to appreciate here is the speed of the gait, the initiation of gait, the speed of the gait, and that can only come with what we call fast twitch muscle fiber recruitment, as shown here. So going on to next, imagine this. This is my patient after a uni compartment totally replacement. Look at a nice vastus medialis. Guess his age. He's 68 years old. That's his age. That's him, 68. This results only can be obtained with the approach that I have shown you, because I have been the other side of the river where I haven't gotten such great results because we haven't been very aggressive enough in the patients before. And that's the type of results patients appreciate from us. So I want to show you a case of patellofemoral pain. This is a common problem that is seen. I just want to keep time in my mind when I talk to you. So I guess I have about 10 minutes to show you my slides, because my time will be over in 10 minutes. So I will go a little faster now. So these are the dynamic causes of patellofemoral pain. These are all soft tissue causes. This is what we have identified in our practice. Hip flexor and adductor tightness will lead to femoral interrotation. Same will medial hamstring tightness. The gluteus medius weakness also does the same. TFL-IT band pulls it the other way. Pronated foot makes the tibia rotate outwards and causes patellar compression. So we have written a chapter on this, and you can see it in the orthopedic clinics of North America, where we looked at all the causes of patellofemoral pain, the dynamic and static. So with the tightness and contracture causes us here, the skeletal deformation is here, muscle weakness and laxity are here. So we can address some of the muscle weakness causes and some of the tightness or contracture causes pretty effectively with many things. So I want to show you an example of case. Again, this is a 10-year follow-up. Now, this is a patellofemoral pain patient. This is the medial side on the left. This is the medial side. This is the lateral side. And you can see with the knee flexion views, the skyline view, the patella is almost subluxed. So the vastus medialis obliquus is stretched out. The lateral structure, the lateral retinaculum is very tight. There's actually slight osteophyte here because this is bumping into the leg of the patient. So that's how I got this patient. And can this patient be treated with physical therapy is a question, and I say yes, and I'll show you the result. So what we did is, this is a 44-year-old patient, used to run up to 30 miles, did 7 marathons, no running for 1 year, very tight iliotibial band. And the findings were tight IT band, VMO, VMO, VL abnormal ratio, weak hip abductors, increased interrotation of the hips, face planus on the left, abnormal movement strategy for step down, and a mild knee flexion contraction. So we had to address all of this to get her better. So we did 12 sessions of soft tissue and A-stim work. We did NMES at home for quad strengthening, manual therapy for IT hip flexor, kinesiotaping for facilitation, hip strengthening, and we followed the squat dive principle of envelope pain, treatment within the pain of envelope. And that's the treatment technique that we used for her. And what did we get? So you can see here, subluxation of the patella, subluxation of the patella. Same patella now within the trochlea on both sides, and patella is not dislocated, and this vastus medialis is now shorter as compared to this vastus medialis. So one is able to actually radiographically prove that the patient is doing better if you are careful in monitoring what you're doing and how you're doing it. And there's a lot of manual therapy techniques we used. We used one of the techniques that's my favorite, where I'll place the patient in a modified over position and come and do a medial glide of the patella or infromedial glide of the patella. I hold it down, and then sometimes I will use soft tissue mobilization techniques right on the lateral pole of the patella. But with that, we were able to get a very fantastic result. Now, results like this have to last the time. So I have a 10-year follow-up on this lady. I keep in touch with her over social media, and she's still very active, not running 30 miles every day, but she's very active, and she hasn't had a problem again. With the stretching and strengthening we did, she improved her position to a point where she didn't need any more further therapy other than tune up once in a while. The second last case I want to show you, go back to very difficult cases. This is a case of epithelioid hemangioma. That's a bone cancer. So because he was being treated for bone cancer, everything else is off the table. The child develops a big flexion contracture. And this was treated at one of the cancer institutes and sent to us for managing this patient. But you're not going to be able to treat in therapy with a 75-degree contracture. Well, how do you treat that is the question. So we got him to about this position. This growth plate is open. He's still young. He was 16 years old when we saw him. So he needed a different strategy. We had to first do a serial casting on his leg to get his leg a little bit more straighter before you could start treating it. And we used a botulinum toxin injection in his hamstrings, did serial casting. Then we started PT. We did the home emergency. He also had a lot of spasms in his hamstrings and gastrocs. So we used some trigger point dry needling for that, fitted him with a walking brace because his quads were so weak that he needed more assistance for that. So let's just go through that. The first time he walks like this, he has a knee flexion contracture, also has a quad leg, and he uses a crutch. The next time he walks a little bit better. Of course, he's still limping, but his improvement is very obvious here. And he's doing better. The next time he comes, He's walking a little bit even better and able to sustain a longer step length. This was about a 3-month period, and he kept on improving gradually. And then one day he came after 3 months, he took the brace and he walked like this. So you can take a 70-degree contracture and very methodically treat the patient to be able to go into a normal gait. This is perfectly normal gait. He's walking with full extension, good quadricep strength, and he did very well. He's now into a school of physiotherapy, and he'll be a physiotherapist very soon. This patient I treated about 8 years ago. So you can achieve results like this. And a last patient I'll show you the case. It's a different case again. The principles remain same. This is a patient who has very short arms and was into a car accident and then needed an external fixator to fix her deformity. And she had a bony knee flexion contracture, but she developed a significant weakness of her quadricep muscle. And the first time she walked, it was very difficult for her to walk. Now remember, she has no arms, so her balance is very poor. So we were able to get her to start. Then we said we were going to do all the therapy we did, the customized bracing, soft tissue, NMES. But we needed to give her a little bit more support. So what we did is we created a custom brace for her where she was able to walk a little bit better, where the opposite leg is able to advance to this leg. So we did the therapy. We continued to do it for 2-3 months. And then eventually we were able to get her to walk nicely. The knee never got fully straight, but our goal of treatment was not to get her knee straight, but to keep working with her until she had good quadriceps and hip control so she could walk better. Well, she wasn't happy with just walking. She actually went in the winter and did what we call snowboarding. So this is her doing snowboarding. And, she sent me a video because I didn't believe, I thought it was just a picture where you can see this girl coming down the snow with a snowboard. And then she also did a 5K in a long marathon. She participated in a 5K. And you can see her come up here. So results like this are possible. Imagination is not, we should not get boxed into just one type of therapy, or we went to one course, so we are going to use it. Our imagination matters, and our participation with patients and dedication of the patient matters. The recovery of the patient happens not just in therapy clinic, but happens 24/7. So giving them more aid, starting with a carefully planned home exercise program to a splinting technique, monitoring that program carefully in order to giving them the devices that are useful, and be aggressive and identify the functional problems right away. All of that put together, you should be able to solve most knee problems. And one of my pet things is, you want a result of a gold medalist in Olympic, don't work like a schoolyard 10th grade exercises. You want a result like that, you're going to work like that. So that's the motto that I drive all my patients. I tell everybody, give me 3 months of your life and I'll give your life back to you. So that's the attitude we have. So we can change a lot of lives as being a physical therapist, as long as we are dedicated, focused, and our patients believe in us. So at this point, I will stop my lecture and I will let the organizers take over my controls again. I know you have a strict time schedule, so I want to thank organizers again for inviting me, and I will stop sharing the screen now.